Okay, so thank you again. No conflicts for this topic. So, first of all, what do we mean by shagiorta? Well, there's a number of definitions, such as the one that you can find here: extensive atheromatous disease with diffuse ulcers associated with soft, loosely held debris and a paucity of actual thrombus. Or the following one, which is really important. It says irregular atheroma surface with finger-like projection and thickness more than 5 millimeters in non-aneurysmal aortic segments. So please concentrate on this part. The thrombus that is within the aneurysm does not count for the shagginess. So it's the thrombus that is in the non-aneurysmal aorta we should be looking at. So there's a number of different classifications. This is the one from the Mayo group that gives points for different issues, such as which segments of the aorta are shaggy, what kind of thrombus, the thickness of the thrombus, area of the aorta involved by the thrombus, the circumference. So you have points for each of these topics, and then you have a 0 to 10 scale. And you can have mild shaggy aortas, 0 to 3, moderate, 4 to 8, or severe shagginess, 9 to 10. And then we have the Tokyo University score, which is a little bit more complex. So it looks at different areas of the aorta: ascending, descending, abdominal, and it gives one so-called shaggy point for each one of these items. So ulcer-like thrombus, thickness more than 5 millimeters, or thrombus more than 2/3 of the aortic circumference. Sorry about that. So, of course, we know that there can be serious consequences of dealing with shagiorta, which are mostly embolic. These emboli can involve the periphery, the lower limbs, the renal arteries, visceral arteries, the brain, the spinal cord, etc. So it has already been shown that aortic shagginess is an important risk factor for endovascular treatment of thoracoabdominal aneurysms, and not surprisingly so. So you see on the right-hand side here, you can see the results in shaggy aortas treated endovascularly, and you can see that there is a large number of organ embolization and infarcts and bowel ischemia. Now, quite surprisingly, you can notice that the mortality in these patients is a bit lower than the mortality in patients with non-shaggy aortas treated by the same group in the same period. But the reason for this is that the non-shaggy aortas are mostly type 2s. So they end up in non-shaggy because they are type 2, so all the thrombus is inside the aneurysm. So it's a little bit complex to interpret these results. Anyway, we have more results from the Japanese group of Kobe that showed that shaggy aortas treated by open repair are have a significantly higher mortality, spinal cord ischemia, acute renal failure, and composite outcome, which also includes multi-organ embolization. So for open surgery, we have a number of possible prevention strategies that includes the administration of statins. However, in order to be effective in stabilizing the thrombus, they must be administered for a relatively long period of time, so this may not be possible in cases which require swift treatment. Then possibly there could be a role for filters. They have been shown to be rather effective in TAVIs, but we really don't know for our thoraco patients. And then also there are these new products that are being developed and studies which are also intended in order to filter the possible debris. And then we have open aorta prevention strategies. Now you can see very well that this kind of aorta that you see here is completely different from the one you have just seen in Professor Jacob's case. So here, what we try to do is to avoid sequential clamping. So we open the whole aorta at the same time. Of course, this comes at the price of more blood loss and more ischemic time for the organs. And then we try to clamp the visceral arteries before the aortic clamping. We just start the pump after everything has been clamped. We try to use usually multi-branch grafts in these cases. But the key is the patient selection. So let's see how aortic shagginess have affected our results. These are the results in open treatment of patients with shaggy aortas in the last decade. You can see mortality was 12%, spinal cord ischemia 10%, stroke 3%, acute renal failure 13%, and any embolization 27%. So how does this compare with non-shaggy aortas treated in the same period? As you can see, these results were significantly worse than the non-shaggy ones. You can see for yourselves how they were almost twice as bad as the patients with non-shaggy aortas. But you could argue that shagginess will in some way select for you patients with a higher atherosclerosis burden, so possibly also patients which have more cardiac atherosclerosis, cerebral atherosclerosis, etc. So we did a propensity score matching for sex, age, extension of the aneurysm, etc. in 48 shaggy versus 48 non-shaggy aortas. And once again, the results became even more significantly, more statistically significant for worse results in shaggy aortas, especially as far as mortality is concerned, acute renal failure, and any embolization. So at this point, we tried to see if the degree of shagginess was important. So we analyzed out of these 58 shaggy patients, we identified 16 with embolization and 42 without embolization. And as you can see, the shagginess score, according to the Tokyo classification, was almost the same, 13 against 12. So this tells us that once we have identified a shaggy aorta, it does not really matter how shaggy it is already a very important risk factors. And this also, we have seen, affects the long-term survival. Here you can see at 5 and 7 years how patients that did not experience embolization during the procedure did significantly better in terms of long-term survival relative to patients with intraoperative or perioperative embolization. So in conclusion, dear Chairman, dear colleagues, shaggy aorta is a risk factor for both open and endovascular thoracoabdominal aortic aneurysm repair. Despite the different prevention strategies, the embolization rate is still relevant during open repair. The embolization does have an impact on early and mid-term survival, and besides better strategy, I think at this point it is really crucial that we use this information to better select our patients for treatment or observation. Thank you very much.